Hi everyone, my name is Kristen Weeks and I'm an MD PhD candidate at the University of Iowa. Today I'll be presenting our study, The Impact of Sleep on In-Training Examination Scores. Sleep deprivation is a fundamental challenge of shift work and has been shown to impact emergency medicine physician residents' performance and coordination. However, it is not known if sleep deprivation impacts performance on the in-training emergency medicine examination, or ITE. The ITE is a written examination administered each year to physician residents. Scores provide information on preparedness for taking the American Board of Emergency Medicine examination. Our team hypothesized that more sleep the night prior to the ITE exam would be associated with higher exam scores. To test this hypothesis, we administered a cross-sectional 12-question electronic survey to physician residents in emergency medicine residency programs in the United States in April 2020. Our sampling frame was residents of program directors receiving the Council of Residency Directors in Emergency Medicine, or CORD, listserv. We constructed a multivariable logistic regression model of scoring at least 70% on the ITE by hours of quality sleep the night before the examination. Here you can see Table 1 showing the total hours of quality sleep before the in-training examination operationalized as a categorical variable in the first row of 6 or less hours of sleep the night before the ITE and more than 6 hours of sleep the night before the ITE. If we look at the last two rows, we can see that hours off service before the exam and percentage on the exam varied by our primary exposure with p-values less than 0.05. Looking more closely at percentage on the exam, we can see of the participants that reported 6 or less hours of quality sleep the night before the exam, 52% scored greater than 70% on the ITE. Of the participants that reported sleeping more than 6 hours before the ITE, 65% scored greater than 70%. Looking in the first column, we can see that total length of residency program, type of residency program, year in residency, rotation at time of exam, and sex did not vary by our primary exposure. Here we can see Table 2, which is a multivariable logistic regression model of the odds of scoring at least a 70% on the ITE. If we look at our primary exposure in the last row in yellow, we can see that hours of quality sleep the night before the exam is operationalized as a continuous variable with an adjusted odds ratio of 1.25. This suggests that for each additional hour of quality sleep a participant reported the night prior to the ITE, they were 25% more likely to score at least a 70% on the ITE. Looking at other variables in this model, we can see that third and fourth year residents were more likely than first and second year residents to score at least a 70% on the ITE. We can also see that residents that reported having off service 19 to 24 plus hours were more likely than residents reporting 0 to 6 hours off service before the exam to score at least a 70% on the ITE. This study finds that increased hours of sleep were significantly associated with higher ITE scores. Given the validated predictive value of resident ITE scores on the American Board of Emergency Medicine qualifying exam scores, results could suggest that the same correlation would apply to the American Board of Emergency Medicine qualifying examination. This study also finds that third and fourth year residents versus first and second year residents and residents reporting 19 to 24 hours off service versus 0 to 6 hours were associated with higher scores. Limitations of this study are a small sample size and recall bias. Strengths are the sampling of a heterogeneous population and the use of a categorical and drop-down questions to limit incorrect data entry. In conclusion, our team feels that attention should be given to shift work prior to the ITE. Physician residents should be given time off the night prior to the ITE to allow for greater hours of sleep in order to optimize exam scores. This is likely a feasible goal given that the ITE is administered on 2 days each year. Residents should be educated about fatigue mitigation and the importance of maximizing sleep off duty. I would sincerely like to thank the co-authors of this paper, Dr. Borhart, Dr. DeFazio, and Dr. Takis. Here's our contact information, and thank you so much for listening.
Hi, my name's Kayla Cohan. I'm here with my colleague, Jody Nim, and we're going to talk about emergency medicine physician stressors, needs, and wellness resources during COVID-19 in New York City. We do not have any financial disclosures. To provide some background, recent literature and anecdotal stories have suggested that physicians on the front lines of COVID-19 have experienced increased psychological burden, including symptoms of depression, anxiety, and acute stress. However, at present, there has been little research yet to characterize these specific stressors and any effective wellness interventions. So our study aimed to evaluate specific stressors, needs, and wellness resources used by the emergency medicine faculty at New York Presbyterian Weill Cornell during the first surge of COVID-19 in New York City in spring of last year to inform best practices to support physician wellness and future public health crises, as well as the ongoing pandemic. In August, we surveyed the faculty here to assess their stressors, needs, and the wellness resources they used during the COVID-19 outbreak in New York City beginning in March 2020. And our survey received 64 responses. Between March 1st and June 30th, of our survey respondents, 28% developed symptoms of COVID-19, 23% were quarantined at some point, 6% received a positive nasopharyngeal PCR swab, and 9% received a positive antibody serology test. We asked our survey respondents questions to have them rate different sources of stress, and we found that physician stressors focus primarily on the risk of infection to oneself and others, followed by the novel nature of COVID, resource allocation and patient care decisions, and changing personal and clinical responsibilities. We also asked our respondents to answer questions centered on PPE adequacy and social distancing in the break room spaces. And we found that, as you can see on the left, less than 20% of our respondents reported PPE as extremely adequate in March, compared to greater than 60% in August, showing this was an acute stressor at the beginning of the pandemic that was at least partially addressed. And as you can see on the right, less than 20% of our respondents felt that the break room allowed for appropriate social distancing extremely or very well, highlighting the lack of social distancing in the break room space as a source of stress due to the potential risk of infection there.
To evaluate physician needs, we asked respondents to rate the most important components of a leadership response. And these included transparency, timeliness, concreteness, compassion, and centralization. And what we found was that faculty valued most transparency and timeliness. And along the same theme of transparency, over 90% of respondents said that it was at least moderately important that faculty be alerted to the number of colleagues ill with COVID at any given time. And then finally, looking at resources, we looked at the wellness resources available to faculty at both the institutional and departmental levels. And what we found was that characteristics of successful resources differed between the two. So looking at the left-hand side, we're looking at the institutional resources. And what we saw was that the most highly utilized resources at the institutional level were these critical job-enabling services. So things like food delivery, parking, childcare, and transportation. Whereas on the right-hand side, while we look at departmental resources, we see that the most highly utilized and most highly rated resources are those that incorporated elements of peer support. So things like DocBox, which is our weekly peer support group, as well as informal group chats. And then looking a little more into DocBox, which was the weekly peer support group, almost 60% of respondents attended DocBox at least once during the pandemic, which you can see on the left-hand side. And as you see on the right-hand side, the majority of people who did attend DocBox were likely to recommend it to a colleague. And they cited things like DocBox was one of the only ways they were able to receive peer support during this time, and that it was a really great way to validate feelings during this time. And then we also used this survey to vet future wellness resources, specifically regular personal wellness check-ins. And what we found was that about 50% of respondents were interested in these check-ins. And for those who were interested, they said they would be most interested in meeting with the EM Wellness Committee on a monthly basis. And based on this feedback, we started to incorporate these wellness check-ins into the department. So then in conclusion, we assert that healthcare institutions must recognize and address physician wellness in future public health crises. Hospital and departmental leadership should consider an increased emphasis on PPE availability, configuration of a safe break room space, and transparent, timely communication. And then job enabling as well as peer support centered wellness resources should be a key element of a physician wellness strategy. Thank you so much for listening to our talk, and we'll field any questions during the Q&A portion of this session.
Hello, today we'll be presenting our project entitled Empathy and Burnout Among Emergency Physicians and Trauma Surgeons. This work was made possible through a grant from the F.M. Douglas Foundation. The authors have no other financial disclosures. Burnout is characterized by 1. Emotional exhaustion, 2. Depersonalization, and thirdly, low sense of personal achievement. We aim to investigate burnout among emergency physicians and trauma surgeons. Because it is not only becoming more prevalent, but perhaps more importantly, it is associated with poor patient outcomes. On the other hand, empathy has been shown to be a protective factor against burnout and to enhance patient outcomes. Empathy can be enhanced through mindfulness practices. While others have studied the relationship between empathy and burnout, our study is unique in that it is, we believe, the first to assess this topic amongst emergency physicians and trauma surgeons, a group which may be at particularly high risk of burnout. To this end, we surveyed emergency medicine and trauma surgical critical care physicians across the U.S. to describe their empathy and the prevalence of burnout. This was an anonymous survey administered through SurveyMonkey that was sent to the program directors of all 99 U.S. trauma surgery critical care programs and a random sample of 30 U.S. EM programs to distribute to all senior EM residents and trauma surgery critical care fellows, 8 EM attendings and 3 trauma surgery critical care attendings from each program. The goal was to sample a large cross-section of emergency medicine and trauma surgery critical care providers who were asked to describe self-reported burnout and empathy. The survey included 50 questions, collecting information on gender, marital status, and parenthood, and participants' exposure to victims of physical violence or potentially preventable death. Also included was the Maslach Burnout Inventory for Health Professionals and the Jefferson Scale of Physician Empathy. Our statistical analysis included assessing internal consistency of the JSPE and MBI with Cronbach's alpha. High and low empathy was defined as scores greater than or equal to 130 and less than or equal to 115, respectively. High burnout was defined as emotional exhaustion scores of greater than or equal to 27, or depersonalization scores of greater than or equal to 10, or personal achievement scores of less than or equal to 33. We compared empathy scores with burnout components of emotional exhaustion, depersonalization, and personal achievement using Spearman's Rho with effect size expressed using Cohen's d, odds ratios, and 95% confidence intervals. Unfortunately, our response rate was rather low at 9.6%. Of the respondents, 66% identified as male, 72.7% were married living together, slightly more than half had children. Most respondents, 65%, were from emergency medicine with 38 residents and 34 attendings. Among the trauma surgery critical care respondents, we had 12 fellows and 26 attendings. The reliability of the surveys was strong with good internal consistency for both JSPE and MBI. We found empathy to be inversely associated with total burnout score. Emotional exhaustion and depersonalization scores were inversely associated with empathy, while personal achievement scores were positively associated with empathy. In our sub-analysis, empathy was found to be similar amongst all groups but lower amongst males. Only 11% of respondents had high empathy scores. Slightly more than half had low empathy scores. Again, these were similar in each group in sub-analysis. Trauma surgery attendings were less likely to have low empathy scores when compared with trauma fellows. Depicted once again in table format, our study demonstrated that trauma surgery attendings were less likely to have low empathy scores when compared with trauma fellows. Overall, burnout was present in 78% of those surveyed. Burnout was less in those reporting exposure to preventable death. Depersonalization was greater among emergency physicians and those reporting exposure to violence. Having children seemed protective against this depersonalization. Depersonalization scores were lower among emergency medicine attendings when compared with EM residents. Our study was limited by a low response rate, especially among TSCC fellows. Additionally, due to the multiple comparisons made, we risk making a type 1 error. Nevertheless, this work demonstrates that burnout and empathy are inversely related with low empathy correlating with burnout. Burnout and low empathy are likely similar amongst TSCC and EM physicians. Empathy may be higher among women physicians and among TSCC attendings as compared with fellows. Depersonalization may be higher among emergency medicine physicians and those exposed to violence, while having children and being an EM attending, as compared with residents, seemed protective against high depersonalization scores. Given these findings, future studies are needed to identify methods to address and enhance empathy and to minimize burnout among both trauma surgeons and emergency physicians.
Hello, everyone. My name is Adrian Cotarello. I'm a chief resident of the Department of Emergency Medicine at St. John's Riverside Hospital in Yonkers, New York. I'll be presenting our project, Effectiveness and Utilization of Hospital-Directed Wellness Initiatives During the COVID-19 Pandemic. It goes without saying that this has been a very difficult year. The global pandemic has taken a big toll on the healthcare system, as well as the different providers in all roles throughout the healthcare system. Physicians in the emergency department were, of course, affected by this in a significant way. So for our project, we sought to determine which hospital-based wellness initiatives that were implemented during the pandemic were both the most commonly implemented, as well as which were found to be the most effective. We sought participants through various EM-specific online listservs, as well as message boards, and this was a cross-sectional survey. Survey was conducted through the SurveyMonkey platform. So inclusion criteria for our study included emergency medicine physicians in the United States, as well as the minor outlying territories. To be eligible for inclusion in the analysis, participants needed to have responded at least one or more wellness questions. So someone who only filled out demographics was ineligible. In putting together the survey, we sought to make it brief to be able to be completed in one sitting. We collected demographic information as well as the frequency of common wellness initiatives, as well as from 1 to 5, a Likert scale response distribution for how effective each of these initiatives were found to be. So the survey ran from July 25th to August 9th. It was distributed through a variety of online message board platforms, including the SAEM listserv, Cord, EMRA, as well as different social networks, including Facebook, Twitter, as well as the Student Doctor Network. So in total, we had 569 total respondents. Of these, 527 were found to be eligible for inclusion in the study. A majority of our respondents were attending physicians at 83%, followed by residents at 13%, fellows at 3%, and a small percentage of medical students. There was a relative split between urban and suburban hospital settings, as well as community and academic centers. Ultimately, here's what we found. So these are ranked in order of most effective. So direct payments, or hazard pay, or hero pay, as some places refer to it, was reportedly the most effective wellness initiative, followed by informal debriefing sessions among staff. Further, free food at work, including from the community, and display of thank you cards from the community. On the lower end, there were psychiatric and psychological services, which we'll talk more about in a moment, as well as the victory song playing overhead. This may have been more particular in the New York or Northeast area. Certain hospitals played kind of a brief clip of a song throughout the overhead systems throughout the hospital during either a COVID discharge or extubation, successful extubation. Was not found to be particularly effective as a wellness initiative. Among places that offered psychiatric or psychological services, the vast majority of participants responded that if it was offered, it was not utilized by most respondents when it was available. Further, we also asked about morale during the peak, as well as the morale at the time of the survey. Again, this comes with the caveat that this is an ongoing pandemic. We're in the New York area, and so our peak was relatively early, but this could change depending on the region. But ultimately, it was found that months after the peak period, morale was actually worse than during it. And this could be for a variety of reasons, whether or not once the peak itself starts to die down, people have more time to reflect on their experience, that may have contributed to a decreased morale after the reported peak. So ultimately what we found, direct payments and hazard pay were to have the greatest impact, but it was actually the least utilized wellness initiative. Again, our sample may be skewed slightly. We had a majority of attending physicians responding, and given the salary difference between an attending and a resident, there may be a difference in how those two groups would respond to hazard pay. Further, many of the donations or the interventions came from the community, food donations and support signs and thank you cards. It's difficult to extrapolate this, whether it had come from the hospital itself, if that would have had the same impact. The community support seemed to be something that was appreciated throughout respondents. Ultimately, informal debriefing is low cost, it's easy to implement, and it's almost as effective as hazard pay, whereas counseling is often suggested and often implemented, but not quite sufficient for the wellness of the respondents. So thank you so much. If you have any questions at all, please reach out to us directly. Hope to see you at the Q&A session. Thank you.
Hello, my name is Stacy Zellman, and I am an assistant professor of emergency medicine at Wake Forest University in Winston-Salem, North Carolina. I am presenting Burnout and the Sexual Assault Nurse Examiner, who is experiencing burnout and why. I would like to recognize my co-author. We have no disclosures and no conflicts of interest to report. The job of the Sexual Assault Nurse Examiner, or SANE, exemplifies the high-stress, highly emotional patient interactions that are often associated with high burnout rates in other professions. While burnout in many other medical fields has been studied, little is known about the factors that contribute to SANE burnout. Our study team set out to assess the types and degree of burnout in SANE nurses and identify both practice and demographic information that may be contributors to burnout in this group of medical professionals. We did this with the goal of helping to reduce burnout in the future. We used the Maslach Burnout Inventory, a validated psychological assessment that measures occupational burnout on 3 dimensions: emotional exhaustion, depersonalization, and personal accomplishment. We utilized this tool to measure burnout in our SANE study group. Our study consisted of an online survey of former and practicing sexual assault nurse examiners within North Carolina. These same nurses may also have practiced or still practice as a nurse within an emergency department. In addition to collecting information from the Maslach Burnout Inventory, we asked our respondents demographic questions such as age, years as a SANE, years as an emergency department nurse, highest degree obtained, practice volume, and percent pediatrics. Approximately 200 surveys were sent out with 95 respondents. The demographics on the left side of Table 1 demonstrate our groups of respondents. We then used these specific groups to statistically evaluate significant burnout factors. As noted in the table, the majority of our respondents are dual-function nurses, currently practicing as both an emergency department nurse as well as a SANE nurse. The median age is 47. The average number of years as a SANE is 8.67 plus or minus 6.37 years. The group with the highest rate of attaining an advanced degree, defined as a master's or doctorate, are those respondents who are current SANEs but have never worked as an emergency department nurse. This second table identifies those respondents meeting threshold levels correlated with Maslach burnout indices. When comparing the 5 different groups of respondents, the yellow highlighted section represents former dual-function nurses, those who previously worked as both a nurse in the emergency department and as a SANE nurse. This group had the highest number of respondents at 55.6% meet criteria for burnout in the areas of depersonalization and emotional exhaustion. The orange highlighted section represents dual-function nurses who currently work both as an emergency department nurse and as a SANE. This group had the second highest percentage of nurses who met criteria for burnout in the areas of depersonalization and emotional exhaustion at 35.7%, compared to an overall mean of 26.7%. This third table depicts the effects of a higher pediatric caseload on MBI scores. The mean percentage of pediatric cases in a respondent's caseload was 37.8%, with a median of 40%. The rows on the table represent those groups of nurses with a percentage of pediatric sexual assault cases either above or less than or equal to the median of 40%. The groups whose caseload was higher than 40% had a higher number of nurses meeting criteria for emotional exhaustion and depersonalization. The nurses whose caseload was equal to or below the 40% median still experienced emotional exhaustion and depersonalization, but at much lower percentages. These results indicate that a higher percentage of pediatrics within a SANE caseload may be an important variable in SANE burnout. Table 4 represents the estimated percentage of total SANE cases respondents performed per year. The mean percentage of total cases per year was 28%, with a median of 20%. The percent of total cases per year was stratified by different SANE groups. While the groups shown in orange, the current dual-function nurses and current SANE nurses who no longer work in the ED, had slightly higher percentages of total cases compared to others, this difference was not statistically significant. We also looked at the effect of emergency department volume and the effect of advanced degrees on burnout, but neither of these categories demonstrated a significant effect on burnout. In conclusion, our study found higher frequency of nurses meeting burnout threshold criteria in those individuals who currently worked in both the emergency department and as a SANE, and those who had retired but had previously worked in both roles. We also found that SANEs with a higher case mix of pediatric cases had higher emotional exhaustion scores and higher depersonalization scores. Exclusive work as a SANE and adjusting or decreasing the mix of pediatric cases per SANE may decrease the frequency of burnout in SANE nurses. A larger study of SANE nurse work practices is needed to help identify those SANE nurses at risk for burnout and how to ultimately reduce and help those that experience burnout.
Hi, everybody. My name is Bernard Chang from Columbia University, and thanks for listening to my abstract. I'm going to be talking about today about some of the psychological and physiological impact of the COVID-19 pandemic on some of our frontline healthcare workers. Just some acknowledgements. Just love to thank the SAEM Foundation as well as the NIH for some of the generous support to allow some of this research. So as a quick background, as many of us know, there really have been some extraordinary psychological stressors amongst many of the frontline providers during the last year and a half during the COVID-19 pandemic. My interest in this has really looked at the intersection of psychological and physical health on our clinicians. Long before the pandemic, I've had some strong interest in looking at the occupational, I would say, hazards of working in emergency medicine. Specifically, how does working in the environment of the emergency department impact our psychological long-term well-being, as well as our physical health as well? In this study, what we looked at were trying to estimate the prevalence of adverse psychological symptoms in ED clinicians working during the pandemic. And we also were interested in looking at its impact on physical health. So not just the psychological sequelae, but also the physical well-being as operationalized through cardiovascular assessments. We looked at a prospective longitudinal study of COVID-19 pandemic working clinicians, individuals who are kind of working during the pandemic in a high volume, high acuity ED, which showed a large number of COVID-19 suspected patients. We included in our sample a diverse group of providers, including physicians, nurses, residents, in addition to non-clinical staff across 4 different EDs in the New York City area. Individuals completed some validated surveys on depression, anxiety, in addition to PTSD, as well as a validated screener on COVID-19 exposure and clinician burnout, the Maslow burnout inventory. We also collected physiological data, particularly accelerometer data, wearing Fitbits, in addition to blood pressure assessments, both during the shift as well as off of the shift. And finally, we collected sleep, some passive sleep data. We also looked at system level information, specifically emergency department level data, the volume of patients, both COVID, non-COVID, as well as like the shift length and the shift acuity for providers. With some of the results right now, we've had some preliminary survey data on about 2,000 participants, which was in a separate subsequent study that found that approximately 60% of individuals were reporting high degrees of anxiety as well as depressive symptoms in the immediate wake of the pandemic. We also, in that subset of individuals, collected a lot more physiological data, as we were talking about before. So we collected their data on Fitbit and sleep. And in this group of samples, we found that these individuals had on average about 5.5 hours of sleep compared to 6.5 individuals prior to the pandemic. And we also found that individuals' blood pressures, the systolic blood pressure, the resting systolic blood pressure was significantly elevated during the months of March and April, and that the time from recovery, so say if you were working a shift and your blood pressure was taken at before the shift, your resting blood pressure took about, on average, about 3 hours to kind of recover after working one of those shifts. We're still analyzing some of that initial data, so we're trying to make a little bit more sense about how sustained that effect was and how that compared to pre-pandemic levels. But there seems to be a suggestion that individuals are not just fired up psychologically, but also physiologically during their shifts. And importantly, there is some type of lag in recovery for those individuals. This data has been used as some preliminary and pilot data for a subsequent larger R01 submission, which we had put into the NIH. So fingers crossed for our group. But hopefully what the hope from this is that we'll be able to create a longer term registry of not just the psychological, but the physiological effects of our frontline workers who've been working through the pandemic here. So that's pretty much a quick overview of some of the work that we have right now. Looking forward to answering any questions that the group may have. Thank you so much.
Hi everyone, thank you for coming to watch this presentation. My name is Jung-Soo Chang and I'm currently a medical student at Yale. I'll be presenting on the research I've done with Dr. Melissa Joseph on burnout and PTSD symptoms among emergency medicine resident physicians during the COVID-19 pandemic. Emergency medicine is a unique specialty characterized by a high volume of decision-making while under multiple stressors, with a research range of 35 to 77.8% of physicians reporting significant risks for burnout. Also, EM physicians are also at an increased risk to develop PTSD, both due to experiencing trauma as well as the cumulative stress of the practice. One study identified EM physician respondents as almost up to 15.8% meeting preliminary criteria for PTSD. With the arrival of SARS-CoV-2 virus in early 2020, healthcare providers across the world were met with a surge of critically ill patients. Northeast, specifically Connecticut, experienced an initial influx of cases during March and April 2020. So in our study, we examined the association between the peak and wane of COVID-19 cases at Yale and symptoms of burnout and PTSD among our EM resident populations. We used surveys to demonstrate burnout and PTSD symptomatology. For burnout measurement, we used the Maslach Burnout Inventory. It's the most widely used burnout index, and it has been validated across many different populations. It's scored in 3 different categories: emotional exhaustion, depersonalization, and personal accomplishment. For PTSD symptom screening, we use the PCL5, which is one of the most widely used to report, and it's based on the DSM-5 criteria. A score of 31 passes the cutoff for positive PTSD symptom screen. So we had 3 survey periods from July 2019 through January 2020, where we had pre-COVID MBI, therefore burnout, data from our EM resident cohort that were rotating through their simulation rotation. In late April and early May 2020, during the first outbreak surge in COVID in Connecticut, all EM residents were invited to complete both an MBI and a PCL5. And we had a final survey administered once the surge had largely subsided, and that was in June 2020. One-way ANOVA was used to determine whether there was a statistically significant difference in burnout symptom categories between the 3 time periods with the COVID-19 pandemic. We used both a paired and unpaired, but however, there was no statistically significant difference in burnout category measures of emotional exhaustion, depersonalization, and personal accomplishment during the 3 periods. We also saw that there was no correlation found between the MBI scores and the inpatient COVID-19 volume at YNHH. This is both a box plot and a scatter plot, where the box plot demonstrates the PCL5 values of the EM residents throughout the study period, and then the scatter plot demonstrates the number of COVID-positive patients at Yale. Of the survey 31 participants, 11 actually scored greater than 31 in the PCL5 during the peak COVID, but we didn't see a statistically significant difference in the actual PCL5 values across the two different time periods. And while a majority of residents reported using exercise and watching TV as a tool to manage stress, we actually didn't see that there was a significant difference in the type of activities performed by the residents based on both the PCL5 scores or the MBI scores. So in conclusion and in discussion, we saw that our work did not show a significant change in burnout symptoms frequency during, and post-COVID surge among our EM residents, which was actually unexpected. Possible reasons could be the work hour limitations, the higher baseline burnout among the resident physicians, or the duration of the pandemic peak, though our sample size is very limited and could be masking significant findings. Our cohort residents did experience significant symptoms of PTSD. Around 35% had screened positive, which is higher than the baseline level of PTSD reported in prior studies of physicians. And as mentioned, our study limitations are limited by our sample size, but we found that it was important that we had pre-COVID burnout data from our residents. But this did limit our participants to the resident cohort that had rotated through the simulation rotation. Additionally, PCL5 is a screening tool and not a diagnostic tool for PTSD. Further interviews and additional things would need to be done to diagnose people with PTSD. We think that the future work would need to compare underlying risk factors for cohort and COVID-19 volume, institutional support, case severity, and other factors in EM residents at large to inform the generalizability of our finding across programs. Thank you for watching this presentation.
Hello, I'm Lucas Seigen, Assistant Residency Director at New York Presbyterian Brooklyn Methodist Hospital. Thank you so much for joining me for this lightning oral presentation. Today I have the pleasure of discussing the association between resident burnout and COVID-19 in New York City, riding the waves. I'd like to thank my team listed here that helped me work with this project. We have no disclosures to report, so let's get right to it. 2020 was the year of curves and waves, whether we were trying to flatten the curve as a society or whether we were riding in between or on the subsequent waves of the COVID-19 pandemic. And water and this beautiful image of this wave has a positive connotation, but we cannot forget its counterpart, fire, or that dreaded burnout, that as residency educators, administrators, ER doctors, people constantly think about. And the media publicized this, no matter what media outlets you followed. And there was data published, literature published on this very topic, and rightfully so, because we were under an unprecedented amount of stress with this novel disease. But there weren't many studies, or any that I could find, that compared the burnout rates pre and post COVID-19. So we conducted a cross-sectional longitudinal study that compared response rates of emergency medicine residents and their burnout using an anonymous platform. Who were our participants? They were PGY1s and PGY2s who work at our urban university-affiliated community hospital, pictured here at simpler and more intimate times. How did we do this? Well, in December 2019, for a different study, they filled out a specific survey measuring their burnout rate. COVID-19 happened. New York City became the epicenter of a worldwide pandemic. And then 11 or 12 months after the initial survey, we repeated before the second wave. How do we define burnout? We used this survey, the Maslach Burnout Inventory, which is a survey that was designed for subjects in the human services industry or educational institution, which fits perfectly for emergency medicine residents. This defines burnout with 3 separate domains or subscales: depersonalization, emotional exhaustion, and personal accomplishment, or really lack thereof. How is this graded? It's a 22-item survey that uses situations and the recipient, or the resident in our case, would have to answer these questions on a 7-point fully weighted scale. So, who is at high risk of burnout? Anybody who scores greater than 10 on depersonalization, greater than 27 on emotional exhaustion, or less than 33 on personal accomplishment. What do we do with the data? We took the descriptive statistics and the resident percentages, and we analyzed them using a paired t-test and a regression analysis to see if there was any difference, comparisons, correlations between the two time periods. What do we find? 21 out of 26 residents completed both surveys, the survey at both periods of time. What do we find? We had 3 who were unfortunately high risk of burnout, meeting criteria for all 3 domains that I discussed a couple of slides ago. 57% had high emotional exhaustion, 81% had high depersonalization, and even 19% had low personal accomplishment. On the repeat test, post-COVID, first wave, 19%, 67, 81, and 24 were slightly worse in regards to burnout, however, not statistically significant. Some more data. As a group, the mean score for depersonalization was high, 17 and 16.9, but no significant difference. Same goes for emotional exhaustion, both high with no significant difference. Thankfully, at least the residents had a higher level of personal accomplishment, 38.6 versus 36.5. Again, no difference. On our regression analysis, there were some changes that correlated with the 2 domains. Depersonalization scores correlated with changes in the emotional exhaustion domain. Maslach et al. Really discussed this correlation between these two domains in the 1980s. So this really validated or confirmed the correlation between them. So what do we find? Despite having high levels of depersonalization and emotional exhaustion, there was no difference in those domains. However, the residents also had high levels of personal accomplishment. This proves the stress of our job. This proves the stress of the situations that we're in, and it really highlights the need to screen burnout of healthcare workers, especially our residents, especially during this very, very difficult time. Thank you so much for taking the time, and I will be here live for any questions. Thank you so much.
Hello, my name is Kyle Yoder. I'm an assistant professor of emergency medicine at Indiana University, and today I have the privilege of presenting our abstract on emergency medicine provider wellness during the COVID-19 pandemic. I have no financial disclosures. So start with a little bit of background. We all know the emergency department is a stressful place to work. Emergency providers report above average levels of burnout when compared to their colleagues. And we know that this burnout leads to impacts on both patient outcomes as well as patient satisfaction in the emergency department, as well as leading to increased rates of substance abuse, suicide, and divorce amongst providers. Layer on top of that a global pandemic, which has been shown to independently increase the rates of depression, anxiety, distress, and insomnia, and you take an already difficult setting to work in and make it even harder. So really the objective of our study was to track the well-being and burnout of our emergency providers during the various phases of the COVID-19 pandemic. We attempted to achieve this through a prospective longitudinal survey study performed from March through November of 2020. We recruited participants from 10 different emergency departments across the state of Indiana, ranging anywhere from single covered critical care, critical access hospitals all the way up to several level 1 tertiary trauma centers. Participants were recruited via email and electronic newsletters within the department. And we developed the survey around 2 different validated wellness scales. The first one being the Well-Being Index, which was created out of the Mayo Clinic. It's a 9-question, 7 yes, no with 2 Likert scale questions that produce a continuous variable that can then be dichotomized down to an at-risk group versus a not at-risk group. And that at-risk group has been shown to have increased risk of reporting medical errors, burnout, severe fatigue, suicidal ideation, and just poor overall quality of life. The second scale we used was the Physician Work-Life Study Single Burnout Question, which is a single question. It's a descriptive scale with 5 levels of burnout. Ranges anywhere from I enjoy my work and I have no symptoms of burnout all the way up to I feel completely burned out and often wonder if I can go on. This can then again be dichotomized into burnout versus no burnout based on the response. We coupled this with our own kind of departmental specific questions that ranged anywhere from 50 to 22 questions that used branching logic and were mainly yes, no. But in each of the surveys, we always included the same core 6 questions that really tried to get at how COVID was impacting them that week specifically. Positive responses indicated some type of impact by COVID during that week. So we had 213 total providers eligible with a response rate of anywhere between 21 and 53%, fairly well balanced between male and female respondents, although our respondents did skew more towards coming from our academic sites versus our community. In general, what we found was for our COVID-specific questions that positive responses started fairly high at the beginning and gradually kind of tapered off over the summer before increasing again when we saw that fall surge in our state. The exception to this being the line in red, which you'll note corresponds with feelings of isolation, which started high, well above 60%, went even higher initially before kind of following the same pattern of the rest of the questions. Our percent screening at risk on the well-being index, very similar to what we found with our own questions. You kind of had this elevated level that kind of tapered off over the summer and then rose back up as the fall came around, with the exception of this week 9, where it had a pretty precipitous drop. Percent screening positive for burnout showed, again, a somewhat similar pattern, although this one had a peak in the middle of the summer as well. You'll see that week 5 surveying where it kind of went up and then had a W shape for the rest of the time. We did correlation analysis on our data and found that screening at risk on the well-being index and positive for burnout on the PWLS correlated with increased odds of answering positive to our COVID-specific questions. Interestingly enough, when we kind of broke it down over time, we found that initially our female colleagues and our colleagues that were part-time had increased odds of reporting or screening positive for burnout and at risk on our well-being index. But as we went over time, that actually disappeared. We also found that our mid-career colleagues had increased odds of screening positive for burnout when compared to their early career colleagues throughout the course of the entire pandemic. So that didn't seem to be affected at all by where we were in it. So some limitations, obviously, at times we had some low response rates and it was a voluntary survey, so that's going to always create some bias. What we kind of took away from our study was that, stress, anxiety, fear, isolation, all very common feelings. They stayed elevated, though they did vary over time. That our screening tools, the standardized tools that we use, correlated very well with our COVID-19 specific questions. And so they probably could be used in place of trying to create your own questions within your department. And the different demographic groups were affected differently at different times and should be considered when you're thinking about trying to implement some interventions to improve wellness within your department. And with that, I will say thank you and would be happy to answer any questions.
Hello, my name is Heather Kelker, and I'm a pediatric emergency medicine physician at Indiana University Health. Today, I will be presenting this work on behalf of the team listed on this slide, demonstrating that COVID-19 is adversely impacting frontline emergency medicine resident and fellow wellness measures. The COVID-19 pandemic has had an unprecedented impact on society that's significantly felt by frontline healthcare physicians, including residents and fellows in training. In fact, these trainees are prone to higher rates of burnout due to an increased workload, sleep deprivation, and lack of work-life balance. We know from the literature that physician burnout affects our healthcare system. It is associated with compassion fatigue, negative patient satisfaction scores, and patient safety concerns. Furthermore, it affects us as individuals. Burnout is associated with anxiety, depression, PTSD, substance abuse, and even suicide in extreme cases. This is a crucial issue to address in our trainees at all times, but especially in times of high stress, such as a pandemic. The objective of this study was to assess burnout and resilience and describe the factors affecting wellness of residents and fellows in an academic emergency department setting during the pandemic. This is a prospective cross-sectional cohort survey of EM residents and fellows from March to November 2020. The population for the study was 73 emergency medicine residents and 16 fellows who were invited to participate in a multi-part survey that combined validated tools to assess resilience, burnout, and wellness, as well as COVID-specific questions that included binary questions, rated scales, and open-ended questions. In addition to binary questions related to COVID-19 shown here on the left, their survey included 3 validated tools. BRS is the Brief Resilience Scale, assessing the individual's ability to bounce back from stress. The Physician Work-Life Study is a single question burnout measure, and the Wellbeing Index identifies those at risk for adverse wellness outcomes. Univariate, multivariate, and correlation analysis using logistic regression was performed across the time points to produce odds ratios between the validated tools and customized questions. Response rates range from 26 to 46 in the early part of the study and had a wide range throughout. Females were equally represented, ranging 44 to 52%, similar to non-respondents. There was a balanced representation of the various postgraduate year classes in terms of responses. All EM residents and fellows reported normal to high baseline resilience scores. This slide shows the results of burnout for residents during the study time period. The most recent Medscape burnout rate for EM physicians was approximately 44%, and prior national studies have put EM physician burnout at around 50 to 62%. This graph shows the key longitudinal responses to our survey's COVID-specific questions. To orient you, the x-axis shows the dates of the time points of our surveys. The light blue bars in the background highlight the initial rise and surge of COVID-positive cases in our state. The left y-axis represents those numbers. The right axis is in the percentage of yes responses from our residents and fellows to our wellness questions. On this graph, the higher the percentage, the more distressed or unfavorable the response. Initially, 90% of residents and fellows had concerns about their safety and experienced stress, anxiety, or fear due to COVID. You can see from the trend lines that this did decrease last spring, but then had several increases and decreases throughout the study period. Also, you can see that there were high levels of feelings of isolation due to COVID-19 throughout the study period, and that even basic self-care was impacted throughout the study time. I will also highlight at the top the lines demonstrating the high level of support that EM residents and fellows perceived during our study period, both in terms of feeling supported by their leadership and having a mentor, colleague, or friend to help them decompress. After correlation analysis, we found that residents and fellows reporting increased strain on relationships had 2.6 times the odds of reporting symptoms of burnout and 4.4 times odds of screening at risk for adverse wellness outcomes such as depression, reporting medical errors, and severe fatigue. Additionally, those that reported increased work responsibilities and that their self-care was impacted, such as getting adequate sleep, nutrition, and exercise, had higher odds of reporting symptoms of burnout and screening at risk for adverse wellness outcomes, as you can see from the odds ratios listed here. Women had slightly greater odds of burnout than men, and PGY3 residents had 1.23 times the odds of burnout than PGY1 residents, and both of these were significant results. Our study had several limitations. Our response rate was not as high as we would have liked, and our survey was prone to self-selection and voluntary response bias. Additionally, due to the anonymous nature of the data collection, we were unable to assess individual trends. In conclusion, the impact of the COVID-19 pandemic on the personal and professional lives of residents and fellows in EM is significant. While residents and fellows are resilient and perceive support from leadership and mentors, during the surge of the COVID-19 pandemic, they experienced high rates of anxiety, fear, distress, and isolation. Strain on relationships and increased work time demands are two areas that appear to correlate with poor wellness outcomes and represent potential areas of focus when considering interventions that foster wellness within EM learners during high stress events.
Hey everybody, thanks for being here today. My name is Abby Schrang. I'm a fourth-year medical student at the University of Connecticut School of Medicine, and this abstract is called Mindfulness Interventions Lower Patient Anxiety in the Emergency Department. I have nothing to disclose. So why am I doing this? Well, before medical school, I worked for 3 years in emergency departments, and that gave me a lot of time to notice that patients are anxious. It also gave me a lot of time to wonder if anything could be done about it. So I want you to take a look at this picture and think about the saying, when a tree falls in a forest, but no one's around, does it make a sound? And then apply that to what we're talking about today. When an emergency medicine provider has to talk to a patient, but the patient's incredibly anxious, can they even hear you? And that's what got my wheels spinning. So when I did research on this, I found 3 key background items that helped me move forward. Number 1, being treated in the emergency department is linked with the development of PTSD. Number 2, mindfulness reduces stress. In fact, it works so well that when you do enough of it, fMRI studies actually reflect changes in the structure of your brain. However, those types of studies take months to progress. So fact number 3, there is something called a one-time standalone mindfulness intervention, and it has been shown to work for people who have never done mindfulness interventions before, and it has been studied in the clinical setting. The specific aims of this study were to 1, measure baseline anxiety of patients in the ED, and 2, see if mindfulness could lower that anxiety. I used the state subscale of the state trait anxiety inventory. I gave people mindfulness in the form of a 10-minute pre-recorded body scan technique. I had them do a second STAI after doing the mindfulness, and then I compared the 2 scores using an independent t-test. The workflow, I tried to standardize enrollment by always approaching people after they'd been seen by a provider. That way I could capture them at a similar moment in their ED visit. After that, I flipped a coin and created 2 groups. The mindfulness intervention group did a baseline anxiety score followed by 10 minutes of mindfulness, and then a second score used for comparison. The control group had a baseline score followed by standard of care, followed by a second score for comparison. What is this STAI I keep talking about? Well, the state trait anxiety inventory is a 40-question quiz that is based on a 1 through 5 Likert scale, and the state subscale is just 20 questions like I feel at ease or I feel upset, and that reflects how someone is feeling in the current moment. And the trait subscale is more likely to reflect someone's overall personality trait, and that is something I didn't want to study in this study. Here's what I used, just a pair of headphones and a cheap MP3 player. I want to show this because I think every single emergency department is capable of having this. The inclusion criteria was kept very broad. You really just needed to be able to listen, and I excluded anyone who required acute, immediate intervention. I was able to enroll 30 adults with an average age of 44. 60% were female, and half the people had at least a bachelor's degree or higher. What were the results? The baseline anxiety was a raw score of 48. That correlates to the 88th percentile. Just for some comparison, the average working adult scores a 35 and the average inpatient scores a 42. So to look at this visually, I plotted those numbers on the normal percentile rank for a working adult. Here at the 50th percentile is the average adult. The inpatient falls at around a 42. And here's the number I measured in this study. The average emergency medicine patient got a score of 48, which correlates to the 88th percentile. Number 2, did it work? Wouldn't you like to know? Well, it turns out, yes, the intervention group on average reduced their anxiety by 12.5 points compared to the standard of care group who actually went up by 2 points. And if we look at that graph again, I just showed with this red bar, this is about what 12 points looks like. And it roughly would get someone with a score of 48 almost down to where the average working adult is. So in conclusion, one-time standalone mindfulness interventions are effective at lowering patient anxiety in the emergency setting. The next steps, a lot more. We need more patients, more types of emergency departments, more types of mindfulness, and maybe more mindfulness or more anxiety measures throughout the course of their stay. I think it would be interesting to do a Press Ganey and see if doing a mindfulness intervention affects that compared to those who get standard of care. And I think it would be interesting to do a longitudinal study to see if doing mindfulness changes the rate of development of PTSD. If you would like to do this yourself, you could go to Google, type in mindfulness UCHC, that's UConn Health Center. Click on that first link and then go to this 10-minute button down here, and you yourself might be able to reduce your anxiety. Thank you, and now I will take questions.
Welcome, I'm Dr. Elizabeth Clare, and today I will be presenting on the prevalence and predictors of distress among emergency medicine physicians during COVID-19. This project was funded by the National Foundation of Emergency Medicine. I have nothing else to disclose. Even prior to the COVID-19 pandemic, physician mental health was viewed as a crisis. Today, with COVID-19, physicians, especially emergency medicine physicians, are facing additional challenges which are only exacerbating existing stress. In order to address physician mental health effectively, it is important that we have an understanding of the impact of COVID-19 on EM physicians and the factors that serve to protect and worsen psychological distress. With this in mind, our aim was to determine the prevalence of depression, anxiety, post-traumatic stress disorder, and insomnia and their association with potential risk and protective factors. This was a prospective cross-sectional survey of EM physicians administered via email from October 6, 2020 to December 29, 2020. Demographic and work-related data were collected from respondents. Depressive symptoms, anxiety, post-traumatic stress, sleep quality, fears associated with COVID-19, and strategies used to cope with COVID-19 were assessed using validated measures. We also designed items to identify any positive work-related outcomes associated with COVID-19. Data on the prevalence of depression, anxiety, PTSD, and insomnia were calculated using descriptive statistics. 3-stage hierarchical multiple regression analysis were performed with the PTSS, anxiety, depression, and insomnia as the dependent variables. Gender, age, living arrangements, and whether they had isolated from family at any point during COVID-19 were entered in Step 1. In Step 2, job stress, stigma, obsession with COVID-19, fear of COVID-19 were added, and coping styles were added in Step 3. Based on well-established cutoff scores and diagnostic algorithms, the overall prevalence of mental health conditions among the sample was 17% for depression, 13% for anxiety, 7.5% for PTSD, and 18.1% for insomnia. Many participants also reported some positive effects of COVID-19, including feeling more appreciated by patients and society, having a greater appreciation and enthusiasm for the job, and feelings of an increased sense of togetherness among colleagues. While the pandemic has negatively impacted the mental health of many EM physicians, it also appears to have led many EM physicians to have a greater appreciation for the value of their job and feel more appreciated by society.